Welcome to Zoom classroom session. Our today's discussion is aortic diseases, and we'll do a brief overview of its management. So let me present my slides here. So aortic diseases, a brief overview. We'll talk about this today. So what are the types of aortic diseases? Aortic diseases contribute to the wide spectrum of arterial diseases and includes dissection and aortic aneurysm also. Acute aortic syndrome includes aortic dissection, intramural hematoma, penetrating atherosclerotic ulcer or traumatic aortic injury, pseudoaneurysm, and aortic rupture. The chronic diseases, the underlying causes are atherosclerotic or sometimes inflammatory affection of the aorta, and the genetic diseases also contribute to the formation of aortic diseases like Marfan syndrome, Ehlers-Danlos syndrome, etc. Congenital anomalies, including the coarctations of aorta, are also included in these disease patterns. So the aortic dissection occurs when a tear in the intimal layer, that is the innermost layer of the aortic wall, causes blood to flow between the layers of the wall of the aorta, splitting the layers apart. It can be defined as acute when diagnosed within 14 days or chronic when diagnosed beyond 14 days. Aortic dissection from the initial intimal tear can progress distally, can progress proximally or in both directions from the point of origin. Anterograde dissection propagate towards the iliac arteries, and retrograde dissection propagate towards the aortic valve at the root of the aorta. Retrograde dissection can result in collapse of the aortic valve, bleeding into the pericardium causing cardiac tamponade, but there is uncertainty whether the initiating event is a primary rupture of the intima with secondary dissection of the media or a hemorrhage within the media with subsequent rupture of the overlying intima. There is controversy about that, but the mechanism is the same. And the classification of the aortic diseases is also important, particularly aortic dissection. There are two standard types of classification. One is DeBakey's classification. There are DeBakey classification groups of aortic dissection anatomically, and this may be type 1, type 2, and type 3. In type 1, it originates in the ascending aorta and propagates at least to the aortic arch. They are typically seen in patients under 65 years of age and carry the highest mortality rate. Type 2, confined to the ascending aorta. Classically, it occurs in the elderly patient with atherosclerotic disease or hypertension. Type 3 originates to the left of the subclavian artery in the descending aorta. Further subdivided into type 3A, which extends distally to the diaphragm, and type 3B, which extends beyond the diaphragm into the abdominal aorta. The standard Stanford classification divides aortic dissection into two groups. This is a straightforward one, the type A and type B, and it has bearing on the management protocol. Group A includes the DeBakey type 1 and 2 and involves the ascending aorta, aortic arch, and can propagate to the descending aorta, and the tear can originate anywhere along the path. So the hallmark feature of group A type aortic dissection is that the ascending aorta is always involved. In group B dissection do not involve the ascending aorta and include the DeBakey type 3. The diagnostic studies are very important. There are a lot of differences between the sensitivity and specificity of the diagnostic tools. The helical CT, it has a sensitivity of 93% and a specificity of 100%. It is most frequently used because it is very rapid and gives a very uh, good result with the helical CT. MRI, it has sensitivity of 98% and specificity of 98%, and it is time consuming, takes a longer time, and the presence of artifact is nearly 60% of the cases. Transthoracic echocardiography, it has a sensitivity of only 59 to 85% and specificity of 63 to 96%. But it may be an initial investigating tool to uh, give some doubt, some uh, indication that the aortic dissection may be present. Transesophageal echocardiography is it has a sensitivity of 98% and specificity of 98% also, but in presence of ascending aortic aneurysm, if the dissection causes aneurysm also, then it will be dangerous to do transesophageal echocardiography. Intravascular ultrasound, particularly useful for delineating the proximal and the distal end of the dissection. Coronary angiography is sometimes needed to delineate whether the coronary ostia are involved or not. Principle of repair of type A dissection. So it may be a simple one like excision of the intimal tear, obliteration of the entry into the false lumen, and reconstitution of the aorta with interpositional graft, plus minus coronary artery reimplantation. Restoration of the aortic valve incompetence is done by valve resuspension, aortic valve replacement, and sometimes aortic root replacement also. Surgical option for repair. The supracommissural ascending aorta replacement, this will be straightforward one. Only the ascending aorta is replaced when the root and the aortic valves are of normal size and when there is no pathology affecting the root or the aortic valve. Composite conduit root replacement, in which the root and the ascending aorta is replaced along with the valve. Aortic valve sparing root replacement. Sometimes the valve can be spared when the valve can be reconstructed. And depending upon the extent of the disease, the hemiarch replacement may be included, total arch replacement, or sometimes the hybrid procedure, that is the frozen elephant trunk technique, is used to replace almost whole of the aorta. So the Bentall procedure is the standard procedure, straightforward procedure, and it needs shorter closed time and the bypass time compared to valve sparing operation. And here the coronary reimplantation is also necessary in Bentall procedure. Potential rationale for valve sparing root replacement. So in this case, the valve can be spared. So valve sparing root replacement is done. Excellent aortic valve function can be restored, having the physiological hemodynamics. And in this procedure, as the aortic valve is not replaced, so there is very little chance of permanent pacemaker implantation because it doesn't produce any heart block. It has a lifelong good functionality and avoidance of reoperation and avoidance of prosthetic valve related complication, particularly with the anticoagulation. So we do not need anticoagulation in this case. How to deal with the aortic arch? The false lumen, that is the DBK type 1 in the arch and the descending aorta remains untreated, something potentially dangerous thing may occur, like aneurysm occurs in 10% of the cases and it may involve the thoracoabdominal portion. Rupture may occur in 10% of the cases. Malperfusion of the organs may occur in 10 to 30% of the cases. And ultimately, sometimes redo surgery is needed, and we do not know the exact incidence of this redo surgery. So, what happens if that remains untreated? The false lumen patency of the aortic arch or the descending aorta, it may give rise to aneurysm formation and may need a reoperation. So the uh, lumen or the false lumen in this case of uh, dissection may remain completely patent, may be partially thrombosed or completely thrombosed. So that is the fate. So in that case, when the aortic arch is involved, uh, total aortic arch replacement in acute type of A dissection may be sometimes necessary. So in that case, radical approach, that is the resection of all disease tissue, may be done, but it has a high risk, high mortality, and increased rate of stroke. But it has a lower reoperation rate and improved event-free long-term survival is there. So in that case, when this radical approach is needed, how to protect the brain? There are several ways of protecting the brain, like deep hypothermic circulatory arrest, retrograde cerebral perfusion through the superior vena cava, or antegrade cerebral perfusion through the selective cannula. Selective arterial cannula like axillary artery cannulation and the left common carotid artery cannulation may be necessary in that case. Is arch replacement beneficial? No difference between the isolated aortic, ascending aortic replacement and the ascending aorta plus arch replacement in the literature with regard to long-term survival and freedom from reoperation. So to deal with the descending aorta, we need to do the frozen elephant trunk technique. So this is a new device which can be used uh, into the descending aorta temporarily, and later on the descending aorta can be replaced by retrieving the frozen elephant trunk device. So this is a very new technique and it makes the thing straightforward. So we can replace the ascending aorta as well as the arch of the aorta. We can deal with it, and the descending aorta can be left uh, 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 with the device inside, that is the frozen elephant technique. It has replaced the elephant trunk technique, because in elephant technique you will have to retrieve the uh, graft material by a left thoracotomy approach and replace the descending aorta. In frozen elephant trunk technique, in the majority of the cases, the descending thoracic aorta replacement is not necessary. So standard is an acute type A dissection. When there is no connective tissue disorder, NTTR limited to the ascending aorta, in that case, root reconstruction and supracommissural ascending aorta replacement plus minus open distal anastomosis is enough. When there are multiple distal entries and impaired brain perfusion and compromised true lumen, total arch replacement plus minus frozen elephant trunk technique is necessary. Whenever there is connective tissue disorder, entity are limited to the ascending aorta. In that case, root replacement with or without valve replacement, that is valve sparing surgery is sometimes possible, plus complete ascending aortic replacement and hemi or total aortic arch replacement may be necessary. When there are multiple distal entries and compromised true lumen, in that case, along with the ascending aorta and root replacement, total arch replacement plus minus frozen elephant trunk technique is necessary. Patient with type A aortic dissection presenting with major brain injury, should we operate on them or not? There is a study in which 1,873 patients were included with type A acute aortic dissection in that registry. Postoperatively, cerebrovascular accident and coma resolved in 84.3 and 78.8% of the cases, respectively. On logistic regression analysis, surgery was protective against mortality in patient presenting with brain injury. So odds ratio is 0.058 and the p-value is less than 0.001. So we see that the tendency is to go in favor of doing the operation. The 5-year survival rate is also very much promising. The 5-year survival rate of this patient presenting with cerebrovascular accident and coma was 23.8%, and 0% after medical management, whereas with surgical management it rises up to, the 5-year survival rate rises up to 67.1% and 57.1% after surgery. So log rank is where the p-value is less than 0.001 respectively. So it goes in favor of doing the early surgery even when there is major brain injury after aortic dissection. In type B acute aortic dissection, when it is less than 14 days, it is a life-threatening condition that is associated with high morbidity and mortality. Complicated type B uh, acute aortic dissection is defined as dissection associated with rupture and malperfusion syndrome, refractory pain, or rapid aortic expansion at the onset or during the hospital stay. Uncomplicated type B as acute aortic dissection is defined as dissection without the aforementioned complications at the presentation. So what is the result after surgery? After surgery, rates of postoperative complication and mortality remains high for patients with complicated type B acute aortic dissection. Thoracic endovascular aortic repair, that is TEVAR, has been shown to be a safe alternative to the surgery for complicated type B acute aortic dissection. For patients with uncomplicated type B AAD, medical management alone has been widely accepted as the standard treatment. However, this treatment course has been shown to lead to less than optimal long-term outcomes with an overall survival rate of 60% at 5 years. In the chronic dissection with aneurysm formation of the descending thoracic and the thoracoabdominal aorta, especially in connective tissue disorder, open surgery offers nowadays the best immediate result with long-term durability. Thoracic endografting plays only a minor role. So in case of chronic dissection, endografting is not the optimum way of treating this patient. In this circumstances, the endografting is not a good option, but branched and fenestrated endografting are very promising technique, but that's technically very much demanding. Hybrid techniques can offer the solution for high risk patients that are not suitable for open surgery. So now we'll switch over to aortic aneurysm. Aneurysmal degeneration that occurs in thoracic aorta is termed thoracic aortic aneurysm. Aneurysm that coexist in both segments of the aorta, that is the thoracic and the abdominal, are termed thoracoabdominal aortic aneurysm. Thoracic aortic aneurysms are subdivided into the following three groups depending on the location. It may be ascending aortic aneurysm, aortic arch aneurysm, and descending thoracic aneurysm or thoracoabdominal aneurysm. Thoracoabdominal aneurysms are stratified according to the Crawford classification as follows. Type 1, it involves the descending thoracic aorta from the left subclavian artery down to the abdominal aorta just above the renal arteries. Type 2 extend from the left subclavian artery to the renal arteries and may continue distally to the aortic bifurcation. Type 3 begins at the mid of the descending thoracic aorta and involves most of the abdominal aorta as far as distal as the aortic bifurcation. Type 4 extend from the upper abdominal aorta and all or none of the infrarenal aorta. Surgical management and indication. Elective repair of ascending aortic aneurysm at 5.5 cm and descending aneurysm at 6.5 cm for patients without any familial disorders such as Marfan syndrome. In Marfan syndrome, 1 cm less. So, in case of a patient with Marfan syndrome or familial aneurysm should undergo earlier repair when the ascending aorta grows to 5 cm or descending aorta grows to 6.0 centimeters. So it is 0.5 centimeter less. The indications are earlier. Using the aortic size index ASI or the aortic diameter divided by the body surface area, one can stratify patient in the following three categories. ASI less than 2.7 per square centimeter, a low risk for rupture, 4% per year. ASI 2.75 to 4.25 centimeter per square meter of the body surface area at moderate risk, that is 8% per year. ASI more than 4.25 centimeter per square meter are at high risk, that is 20 to 25% per year. Surgical treatment of ascending aortic aneurysm. Ascending aortic aneurysm with normal aortic valve leaflets, annulus, and sinuses of Valsalva are typically replaced with a simple supracoronary dacron tube graft from the sinotubular junction to the origin of the innominate artery with the patient under cardiopulmonary bypass. If the aortic valve is diseased but the aortic sinuses and annulus are normal, the aortic valve is replaced separately and the ascending aortic aneurysm is replaced with a supracoronary synthetic graft, leaving the coronary arteries intact, that is the Whit procedure. But when the sinus of Valsalva is also aneurysmal, sinus of Valsalva aneurysm with normal aortic valve plates and aortic insufficiency due to dilated sinuses may be repaired with a valve sparing aortic root replacement. Two valve sparing procedures have been developed, the remodeling method and the reimplantation method. The remodeling method involves resection of the aneurysmal sinus tissue while maintaining the tissue along the valve leaflet and scalloping dacron graft to form new sinuses to remodel the root. The reimplantation method involves reimplanting the scalloped native valve into the dacron graft. Both require reimplantation of the coronary ostia into the dacron graft. Aortic valve plus root replacement. Patients with abnormal aortic valve and aortic root require aortic root replacement. In non-elderly patients who can undergo anticoagulation with reasonable safety, the aortic root may be replaced with a composite valve graft consisting of a mechanical valve inserted into a dacron graft coronary artery reimplantation, classic or modified Bentall procedure or Cabral procedure. For elderly patient, young active patient who do not desire anticoagulation, women of childbearing age, and patients with contraindication to warfarin, the option includes stentless porcine root, aortic homograft, or pulmonary autograft, that is the Ross procedure. For elderly patients who cannot undergo a complex operation, another option is reduction aortoplasty, that is the wrapping of the ascending aorta with a prosthetic graft. Aortic arch aneurysm and more. So, hemi-arch replacement may be done, total arch replacement may be done, and elephant trunk procedure can also be done. In elephant trunk procedure, dacron grafts used to reconstruct the transversion distally in an extended sleeve that is telescoped into the descending thoracic aorta, facilitating later replacement of the descending thoracic or abdominal aneurysm, that is a two-stage procedure. Hybrid procedure represents a combination of open and endovascular procedure. Frozen elephant trunk technique, which involves standard ascending and arch repair, as in the elephant trunk procedure, followed by antegrade reconstruction of the descending thoracic aorta through the open transverse arch. Descending thoracic aortic aneurysm and the thoracoabdominal aortic aneurysm. Descending thoracic aortic aneurysm may be repaired with open surgery or, if appropriate, with endovascular stent grafting technique. Surgically, descending thoracic aortic aneurysm may be repaired with or without the use of a bypass circuit from the left atrium to the femoral artery or femoral bypass, that is femoral vein and femoral artery cardiopulmonary bypass, depending on the length of the anticipated ischemic cross-clamp time and the experience of the surgeon. Proper type 1 thoracic aortic aneurysm involved dacron graft replacement of the aorta from the left subclavian artery to the visceral and renal arteries as a bevel distal anastomosis using sequential cross-clumping of the aorta. Proper type 2 thoracoabdominal aortic aneurysm repair requires a diaphragm graft from the left subclavian artery to the aortic bifurcation with reattachment of the intercostal arteries, visceral arteries, and the renal arteries. Proper type 3 or 4 thoracoabdominal aneurysm repairs, which begin lower along the thoracic aorta or upper abdominal aorta, may use either partial bypass of the left atrio to femoral artery or modified atrio-visceral or renal bypass. This is all about the management principle of uh, dealing with the different types of aortic diseases. This is in brief, and we haven't given the detail of the operative procedure. We have talked about the principles of the surgery only. Thank you very much.